I think septic shock remains a huge global problem. And I think it's tragic to see the amount of life lost in low middle income countries and in regions that, even within Canada, hospitals that don't have access to ICUs, right? For them to send a patient to an intensive care unit with sepsis, they have to, have a critical care flight team go over and pick up the patient and bring them back.
Damn.
Sometimes they're not stable enough to do that. To have a treatment that they could just use right there is something that I think is compelling. Even if you were really just concerned, like we need to fix sepsis in Canada right now, before we think about other things, I would tell you that there are really actionable ways that we can do that, because not every center is Lakeridge Health with a 40-bed ICU with access to basically everything we need. A lot of areas and parts of Canada that don't have that kind of access, or to get it requires substantial transport. So to come up with ideas like that can assist in those situations, I think is particularly exciting.
No, I didn't go back to school. Plus, I've got like 15 grand in student debt, and I can't handle any more of that. We're in the Learn Auditorium at Lakeridge Health, and this is the same auditorium where healthcare staff are talking about the amazing innovations that are happening right here in our community. I was floored to find out at any given time, 130 studies are taking place, including some amazing clinical trials. Over 80% of healthcare happens in community hospitals like Lakeridge Health, which is why it's so important for studies to happen in these places. We have two phenomenal guests today, including Carly McPherson, who's the Director of Research at Lakeridge Health, and Dr. Shannon Fernando. And remember that name because this guy's about to be famous. He's currently leading his first study. It's completely donor funded, and it's all about finding treatments for sepsis. This is going to save lives, and it's amazing to know it's happening right here. So let's brace for impact with Carly McPherson and Dr. Shannon Fernando. Well, welcome, friends. This is so much fun. We're just going to pretend we haven't been sitting here in awkward silence for a couple of minutes, and that'll break the ice. I think the ice has been successfully broken. I want to find out what you both do here. Dr. Shannon Fernando.
I work here as a critical care physician. So I work in the critical care unit. I take care of patients on life support. So usually very high stakes, but in a very controlled manner with an amazing team. I'm the research lead within the Department of Critical Care. So I am usually the principal investigator on the various trials that we have running. And my last hat at Lakeridge is I'm the medical director of trauma. So I manage the trauma program here, which is operating at all of the various sites and ensuring that we optimize care of patients who are injured in trauma.
Well, I'm an experiencer of trauma, usually just emotional. Carly, what do you do here?
I don't have nearly as many hats as Dr. Fernando does. I think I need to make some up. But I am the research director here at Lakeridge Health, and it is looking at expanding research to all sites. Currently, right now, the largest concentration of research we have ongoing is at Lakeridge Health Oshawa, but we also have studies ongoing in our Whitby site as well as our Ajax Pickering, and hoping to expand to Bowmanville and to Port Perry in the near future. So that would be great. And I'd be remiss to not mention our long-term care facility, the Lakeridge Gardens. So we're looking at expanding research studies into that area right now as well. So I oversee the clinical trials unit, and that's sort of the bread and butter of the research program, and then also administrative support for our research ethics board. But what I'm also looking to do is just expand services. So how can we help operationalize research ideas and studies like Dr. Fernando's, which we'll talk about here today? And, how can I help apply for funds? How can we support you with developing your own proposal? What sort of inquiries do you have? What sort of education and training can we bring? So really looking at a large variety of services within the hospital.
And you don't think that's enough hats? That was a lot of hats.
No.
That's a lot of hats. That's a whole wardrobe.
That's just stuff.
That's a hat store.
Yeah.
Today we're in the Learn Center. It's this beautiful auditorium. There's a bunch of other things here that have also been funded in addition to the auditorium by donor dollars. What do we do here?
What we're able to do down here within this auditorium, and then there's several meeting rooms around here as well, is we do with that Queens Lakeridge partnership, this is training the next MDs fit for family medicine. And so we're in the second cohort right now, and we're looking at adding more family doctors to the region because I think we're at about either 60,000 or 80,000 individuals who are unattached patients,
That's
meaning
nuts.
that's an individual that does not have a family doctor. And I don't know about you, but even just getting to my family doctor, there's a wait time, right? So we need more physicians in the area to help those patients. And so this whole Learn space is where the students are coming and learning, receiving their curriculum to become family medicine
Yeah.
physicians to hopefully help, stay and reside in the Durham region and support more of our patients. So yeah, it's fantastic. But the Learn Auditorium, it's not just for them, it's for the whole hospital network. And so we have other programs who are coming down here. We're looking at different grand rounds, different departmental rounds. For instance, we have in the research program, we actually just launched it in the fall. It's called Research and Innovation Rounds. And so we seek educational bursaries from outside companies, and they actually support catering. Everybody likes to be fed.
Nice.
Come down here and to learn either internally about new initiatives, new projects like Dr. Fernando's that's ongoing, or hearing from other scholars.
Patient care, day-to-day patient care, incorporating it with research and using it to answer really fundamental questions in care is something that has sort of been there that I think a lot of people don't know about. And I think that that's one of the exciting things about launching research here at Lakeridge.
So what are some of those, maybe Carly, you can help us out with that. What are some of the questions that we're answering with this research?
So actually, our research spans a large number of areas. We do different types of research, all clinical. And so what we can be doing is clinical trials where we might be looking at something like an investigational study. So it could be a new drug treatment, for instance, a new way to look at seeing if we can minimize symptoms or create greater efficacy for curing something like cancer, a particular area.
Big fan of that.
Yeah,
of the curing cancer,
I
you know?
think, yeah, very important. And I would say that's one of our larger areas. But then we also dabble into other areas. Critical care is obviously a very large area that we work on, especially with Dr. Fernando, but then also in pediatrics, nephrology. We're doing more studies in our emergency department, but it's not always an investigational study in that sense. Sometimes we're looking at observational studies. So we could be doing interviews or questionnaires, really looking at quality of life, because that's really important. If we have something that's doing really well, it's really effective for our patients, that could be great. But as you know, with any treatment, a lot of times it comes with a lot of other symptoms that can creep up as well. And so, yeah, if we can minimize that as we go on, not only to have greater efficacy in that treatment, but minimize sort of the counterproductive aspects, those greater symptoms that creep up, then, that's just going to advance the area altogether.
Yeah, that expression, no such thing as a free lunch. Like I've been cancer-free for almost 4 years now. It'll be 4 years in August. But I can barely feel my hands and feet. And I'm like happy to be alive, happy to have something to complain about, than, the opposite of that. When we're talking about, actually, could I ask you a question about like my personal case?
Sure.
So I had immunotherapy. I had a drug called brentuximab a couple of years ago.
Okay.
And it's been approved by OHIP for like the aftercare, maintenance care after a stem cell transplant, which is what I had. But it was still, I think, considered like a clinical trial before I had the actual transplant. They mixed it with another cancer drug, bendamustine, another chemo drug rather, and then that combo was the only thing that seemed to work on me. When you're dealing with patients and you're suggesting clinical trials to them, how does that whole process work? Like you're dealing with someone in cancer care or critical care. Do you have a master list of like, we try these things? What's the process?
Yeah, so I think any treatment that's being tested, and I think it's important for patients or prospective patients and families to know this, is that any drug or treatment that's being tested certainly in critical care, any other aspect of medicine, has to go through a huge process in terms of regulation and oversight. So that often always will involve a research ethics board to some degree. And so the study has to be ethically approved or something where there's at least enough uncertainty about whether the treatment is better than what is already established standard care. And then certainly in drug trials, there's also oversight from federal agencies like Health Canada. So our general approach is reassuring families of that. I think for us, we're often not speaking to the patient directly. I think your situation when you're being consented for a cancer drug is a little bit different than our situation because most of our patients in the intensive care unit don't have capacity to answer questions. They're often sedated. They're often very too sick to have capacity for decision making. And so we're often talking to families. And it's
and they're scared already,
scared.
right?
They're scared already.
Yeah.
Those are scary words,
a lot to
clinical
go
trial.
through.
And you also have to keep in mind that their loved one is critically ill. They're in the intensive care unit. They're just hoping we don't breathe too hard on them and things go, the wrong way. Now to then approach them and say, we were hoping, or your loved one is eligible to be enrolled in this randomized trial for an experimental therapy is a hard sell because then suddenly they're like, well, you already told me that they're sick, and now you want to experiment on them. So the way you actually consent somebody, the way you approach them is super critical in terms of getting patients into trials appropriately and ethically. One of the things I always tell families, and I think this is often true, is that most of the things we do in intensive care particularly are because of previous randomized trials and because previous patients have been enrolled in trials or agreed to be enrolled in trials, and that information we're now using to treat your loved one. And I often say, this is a way potentially for you to give back to future generations, and oftentimes that is something that people consider. Along with the fact that there's appropriate oversight, they have the option to withdraw from a study at any time, but also to know that this information is being used to change care, whether to stick with what we're doing or do something different, and then help people going forward, I think is an important viewpoint to express to prospective patients and substitute decision makers in a already very high stress, high stakes situation. So I don't think it's that drastically different from being a patient with cancer who's being considered for a drug. You also, have an established standard of care, and you're like, do I want to go this way of trying something experimental or something, that's different from what is normally used? And people need to be reassured that there's a lot of oversight and regulation to that.
Mm-hmm. Yeah, it's interesting that you're talking about the difference between dealing with someone directly like myself. I was 29 when I had cancer. And I'm like, I'll take whatever you got. What do you got in the cupboard back there? Versus, and I can make that decision for myself, and
Right.
I'm the one who is making that decision. But if I had to make that decision for somebody else, I think that I would be, it's impossible to say. I might be more apprehensive. And that's kind of the difference you're seeing? If it's the patient themselves, they're going like, yeah, absolutely, like whatever. Versus a caregiver, maybe, let's take a couple of minutes to think about it.
Well, I would also say it depends on where you're meeting that individual. So what's their background, either yourself or that family member? Have you heard about research before? Are you familiar at all? Or what is that patient's journey, whoever we're discussing, what's that journey looked like? Because if, for instance, if you're looking at an initial diagnosis, somebody might want to sort of sit back and contemplate. But if you're further along in your journey, you might be sitting there and going, yeah, I'm still fighting. I'm
today.
still at this. Yeah. And so give me what's out there. But it's also based on what's available here at our hospital at Lakeridge Health. And so, we're looking to see whether you're even eligible. From our standpoint, we really look to approach anybody who's eligible whatsoever, and then just allow that time for them to make that decision themselves. And to ensure that, as part of that informed consent process, we're not rushing anybody. Take all the time that you need, ask all of the questions. You want to go home and speak to other loved ones, consult with other people. That's okay. Usually a little bit more time sensitivity in critical care, just because you're dealing with, different circumstances. Sure. But something, for instance, in your own journey, if you're dealing with cancer, then you might want to take a little bit more time to consider that, or come back and ask more questions.
And then when you're doing a drug trial and you're talking to somebody and asking them if they want to enroll in this, and it's a random, can you explain what a random drug trial is? Because I've heard the term it's a blind, it's a double blind. How does that whole process work? Is every clinical trial random?
So not every single clinical trial is randomized. Randomization is strongly considered like the gold standard. Mm-hmm. If you want to do a trial in the best way, you want to randomize who gets drug A versus drug B. And the reason is because if you just leave it up to clinicians to decide, they will probably decide that certain patients are better for drug A and certain patients are better for drug B.
Based on what, though?
Well, there are predetermined condition, conceptions of whether the drug works or not, their idea of what that patient is and whether there's somebody who might respond to the treatment. So you can't really leave it up to clinicians. You really want it to be truly based on the next person through the door randomized. So it takes away sort of all of those what we call confounding factors or other things that might, just to make sure that there's balance between the two groups, that the ages are about the same, the comorbidities or other conditions are the same between the two groups. And so that is a really a critical aspect to doing a very good trial, is to ensure that the patients have been randomized. Nobody chose who's going to get treatment A versus treatment B. It's a way to protect against bias. Mm-hmm. And then further to your question about protecting against bias, you also don't want the treatment teams ideally to know who's getting drug A or drug B, because we all have subconscious biases about whether we think a drug works or not, and you really don't want people to know that. And so what we will often employ, if possible, is something called blinding, as you discussed. So that's when you take drug A and drug B and you basically present them in either the same pill or the same bag, or so nobody can tell which one they're
presented
getting.
in the same way.
Yeah,
Yeah.
nobody can tell which way they're
So
getting.
you mean
And
like there are two sandwiches here. You
Yeah.
can't see what's inside.
They
one has
look
peanut
identical.
butter
Yeah.
and one has mayonnaise.
correct.
Yeah.
That's exactly the best way to put it. Like the outward vessel looks the same, but the drug is, and nobody knows, include the patient, their loved ones, the team taking care of them, and even the experimental team, who has been assigned to what. Only people, there's a one master list that usually one person is aware of, and they're the person who knows who got drug A and drug B.
It's like the 11 herbs and spices.
That's right.
There's like one person who has the master
That's,
list.
yeah,
Okay.
it's, you know, it's protected, and it ensures that our preconceived notions, our subconscious biases about whether a drug works or not, don't work their way into our decisions around that patient. And it is very powerful in that way, in ensuring that, you know, we're eliminating our biases and really seeing whether that treatment works versus what we're comparing it to.
And then how do you stay organized? Because like, you know, you've got the drugs, you don't know what they are. Like, is it like an Excel spreadsheet?
It's a really efficient clinical trials team. So working alongside the physicians as well. I mean, you would manage any of those study materials in any other way. Sometimes some of these items are held within our pharmacy department. Other study materials might be held within the research department. And yeah, you know, there's a variety of things. It depends on the sponsor as well. Sometimes there's different portals. Sometimes there's Excel spreadsheets. But organization is certainly key.
This isn't like the back of like a bank envelope, like
No
a grocery
scratch
list?
notes.
No, you don't
Yeah,
want
yeah.
that.
We're not working on little sticky notes.
And then how many of them do you have running at the hospital right now? Like how many is Lake Ridge dealing with?
So we have about 130 research studies ongoing
Damn.
at any given time. Yeah,
Okay.
it's quite a large number. And I think a lot of people are really surprised to hear that, because quite oftentimes Lake Ridge is considered, you know, we're grouped in with that community hospital name. But I think it's name only because we are a health system. We have 5 sites. We've got all of these community sites that we work with as well, a long-term care facility. And our research really extends into all of these areas. But of that 130, it's a variety of different types of studies. About 85% are clinical trials, though.
Wow, okay.
Yeah.
What are the other 15%?
So we would be looking at qualitative studies. It might be chart reviews, retrospective reviews, going back and looking at, you know, trends in data. So things like that.
And then why would, like if you're dealing with a research center, right?
Mm-hmm.
And then you're doing the clinical trials here, what is so attractive about this hospital system in particular? I mean, like everyone's great, you know, like we've
Yeah.
got some beautiful spaces and
Yeah.
we'll talk about this one in particular in a bit, but why, I see Queen's University all over the place down here, for instance. How did that partnership come about? And yeah, why is this so attractive?
Yeah, absolutely. So, I mean, I can answer first, and then Shannon, if you want to hop in as well. But I think that part of the attractiveness here is we have a really long track record. So we've been doing clinical research since I think probably about the early 90s. And it's really about that efficiency, and we've grown the number of members, the physicians, the healthcare professionals, our clinical trials team, who've been able to support those trials. And I think if you get a good name, right, then people are more likely to come back to you.
A good
And
name being?
a good name meaning that, you know, you're easy to work with, the relationship is there,
reputation.
good
Okay.
reputation. Yeah, you know, the data that you provide back to whoever the lead site is, they're looking at it and saying, wow, it's really efficient, it's really clean, it's really high quality. And I think that our turnaround times are really good too. And so that's something that we really boast about, is because not only is it important for the sponsor, whether it be a pharmaceutical company or if it's another, you know, say downtown hospital or another university. A lot of times what they're looking to do is, you know, they have this idea, they've been working on it potentially for 5 years, 10 years, 15 years. It's finally getting to a point where we're running a clinical trial, for instance. Well, you want to get that open. You want to open it in as many sites or centers as need be. And if you have a requirement to bring in patients, then you need that to be done well and efficiently. And if you have a streamlined process where we're able to open within only a few months, as opposed to looking at a year, because there could be administrative hurdles, some breakdowns along the way. If you can open sooner, not only can you bring in patients sooner, but then you can respond back to whoever the sponsor is, give them that information. They can then start working on the data, looking at the analytics. You know, what does this mean? What are the study outcomes? Is this better? Is it not better? They're able to get that results. But I think part of it for us too is that we're based within the Durham region. We have a huge catchment. And so we have about 750,000 individuals
a lot
who
of people.
reside in this space. Yeah. And so I think that we have a lot of opportunity to provide that access. And so if you're working with a center like ours, not only do we have the people, but we've got the teams. And, you know, at the end of the day, it's really all about our patients, though, and it's offering that access to them. And if it does challenge standard of care, and if it is better, then that means that we get to change our practice here. So it's better for the community overall.
Yeah. Dr. Fernando, can you talk about some of those changes that you've seen implemented over time, specifically here with your patients? Like Carly, you were just mentioning that we know better, we do better, basically.
absolutely.
What has the doing better been like lately?
So I would say that, you know, I've been at Lakeridge for about 3.5 years, coming up 4 years now. I think certainly there's been a huge growth in research, particularly within critical care. To Carly and I both, before we were at Lakeridge, were both at pretty large research institutions at large metropolitan areas. What I would say is that you know, research is funded, at least most institutional research is not by private industry, it's funded by government organizations. So Canadian Institute of Health Research is predominant. When we talk about CIHR, that's taxpayer money that's being given to do research studies. It's not ideal, and I think their mandate is to ensure that all the people who are enrolled in trials are representative of the people across this country.
Yeah, that's huge.
And you know, if you're just enrolling at really large centers, you're only getting the people in those really big cities. And to Carly's point, you know, 750,000 people in Durham who aren't represented then in clinical trials. CIHR will come back and say to you, but how confident are you that these results will apply to anybody in this country, regardless of where they're from, regardless of their socioeconomic status, regardless of their background, whatever environmental exposures they might be exposed, like they might have to deal with. And therefore, there's a huge mandate from these funding organizations to ensure that quote unquote community hospitals or smaller hospitals in other regions are involved in research. Lakeridge is kind of like the best of both worlds. I always feel in that way because you know, we're kind of thought of as a community site, but the truth is, you know, we have 5 sites within the Lakeridge network. Our critical care unit in particular is very academic. We have residents who rotate through, fellows who rotate through. They're used to being involved in research studies and seeing, you know, high-level academic endeavors being taken up. And so I think, you know, what we have been able to do is quickly ramp up our research so that originally, you know, we're starting to do studies that were sponsored by other sites and now moving towards trying to do our own research. And also, you know, we're seeing residents who are coming in and understanding that, you know, you're seeing the very, very cutting edge of research being conducted right in front of you. Like, you know, even today I'm on service in the intensive care unit. On rounds, we're taking care of patients, and I'll say, you know, would you use this treatment in this patient? And the resident will say, I'm not sure. And I say, actually, we're conducting a trial on this exact question right now with some other patients who are enrolled in that exact trial.
You're like, the timing could not be any better for this right now.
And I was like, you're seeing, you know, academia and academic growth directly in front of your eyes. And I think that that's valuable when you're coming from an educational or training perspective. So, you know, these are just changes I've seen over the last 3.5, 4 years. I really think, you know, the sky is the limit. Like, I just think that there's a lot more growth available to us when you're talking about such a large catchment area, such a diverse patient population, and such a, you know, quite dramatic breadth of illness. Like, we see very, very sick people here at Lakeridge, unfortunately. So it's really, it shows, you know, what we can accomplish, and I'm really hopeful that there's going to be more going forward.
Well, and you're working on a clinical trial right now to do with sepsis, right?
Yeah.
What has that looked like? How do you expect that to evolve? How do you expect that to change with what you're learning right now?
So, you know, septic shock is you know, something that not a lot of people really know about, but it remains, you know, one of the top 10 causes of death in the world. Yeah. So
wild.
Sepsis is the body's response to infection. It's not necessarily infection itself. It's the way your body might respond to getting an acute infection. And it results in organ failure through a complicated immune process. And what's amazing is over the last 20, 30 years, mortality from sepsis is still very, very high. You know, and in particular, I think what is important, and you know, this is survival from septic shock is a pillar of the World Health Organization. You know, it's one of their 5 pillars of things that we really need to fix going forward. And that's because sepsis disproportionately affects people in low and middle income countries who die from infection all the time that is readily treatable. But the care of patients with septic shock is expensive. It's resource consuming. You're talking about admitting someone into an intensive care unit, often requiring pretty significant life support to make sure their organs work well, dialysis if their kidneys fail, mechanical ventilation if their lungs fail. And so there's a really urgent need for further therapies that can improve outcomes. And so, there are certain, the solution that we're investigating is something called methylene blue, which has been around for decades and is around and is not on patent, not owned by any pharmaceutical company, very cheap, readily available and usable, and has been used for decades. And people have routinely used it, in a patient who's very, very, very sick, near death, as a last-ditch thing, and it doesn't work, and then people throw it away. But the truth is, if you start using it earlier, perhaps there's a signal and benefit. And so we've, presented this idea nationally at trials, at the Canadian Critical Care Trials Group, and had really great response. And a lot of people are like, "This is the time to study this. Can't believe this hasn't been studied," because it's a drug that's readily available, relatively cheap, doesn't require any sort of special training to give it. So therefore, it could be used in Canada in emergency departments, on the hospital wards, in the ICU, but it could also be employed in low middle income countries where it can help, potentially improve the outcomes of patients who might otherwise get so sick that they might not have access to the life support that they need. So, it's a compelling story. And, certainly there's a lot of work to be done to get it that way. But we've had amazing support here at Lakeridge, as this being, one of the first investigator-led trials here. And a lot of people who feel that this is an important research question that we should study. So, it always starts, and I think what has been daunting to me for, pretty early in my career, this is the first trial I've ever led, is the amount of work.
This is the very first one.
This first trial I've ever led.
How does that feel?
It's daunting.
Yeah.
It's definitely.
It's exciting.
It's exciting.
Yeah.
It is definitely, but because there's a lot of support, and you want to definitely put your best foot forward. And I think what's really exciting is, you're starting with an idea, like this is an idea I have, and then you're saying, okay, this is the evidence that exists that supports this idea. And then, we're really grateful through Lakeridge Health Foundation to get funding to start doing the basic work to prove that that's important. Mm-hmm. And I'm happy to say that work has panned out and has really helped us make a compelling case. And now taking that case to large federal agencies and saying, this is why you should fund this study. So that's where we are right now. But it's exciting to even, we got that grant early 2024. We're about a year out to where we've been in a year. And the support from Lakeridge and Carly and our research team to meet us at exactly, where we're going is really exciting.
That's
and
awesome.
I think, it started off very daunting, but it seems doable now.
Yeah.
It's like in the back of the head, I'm still like, there's still so much work to do. But when you're doing research, you're doing it because you're passionate about it. Mm-hmm. And you think that you're going to make a difference for people and change care for a huge proportion of people who are getting very sick and dying from something.
Well, and batting 1,000 so far. One of one that you're leading. It's working. Hang it up after this
I'll tell
one.
you, that's it. I'll retire.
Why this thing in particular? Is there a personal connection to this? Is there something that, what was that moment for you?
I wouldn't say it was a particular moment. I think my very first patient I ever took care of in an intensive care unit had septic shock, and then I realized it's very common. If unfortunately you go to any intensive care unit, you'll probably see 15-20% of patients at least with septic shock. It's incredibly common. It's bread and butter in intensive care. And so in so many ways, we know how to deal with it. But it's still remarkable, that there's potential treatments out there that have never been tested in randomized trials. And it was, methylene blue is something that even from the time I was a resident or fellow, staff physicians would tell me, you could use this. It might work. If you try it, but usually we wait until the patient's a lot sicker and then we'll use it. And I was always kind of curious as to why you would wait. And
why so late?
I think that's just the way practice had evolved. It's the idea of using, and I think what I love about research is taking things that have become sort of standard of care and thinking about it in a different way. And what instead of giving this very late, we gave it very early, and then maybe the patient wouldn't need as much life support because their blood pressure gets better and their organ function gets better, and that has a lot of benefits even in and of itself. So I wouldn't say it was a particular thing. It's just I think septic shock remains a huge global problem, and it's not preventable as it is treatable. It's tough to prevent sepsis when it happens, but you can treat it, and we can see patients get better. And I think it's tragic to see the amount of life lost around the world in low middle income countries and in regions that even within Canada hospitals that don't have access to ICUs, right? For them to send a patient to an intensive care unit with sepsis, they have to, have a critical care flight team go over and pick up the patient and bring them back.
Damn.
Sometimes they're not stable enough to do that. To have a treatment that they could just use right there is something that I think is compelling to, even if you were really just concerned, like we need to fix sepsis in Canada right now before we think about other things, I would tell you that there are really actionable ways that we can do that. Because not every center is Lakeridge Health with a 40-bed ICU with access to basically everything we need. There are a lot of areas and parts of Canada that don't have that kind of access, or to get it requires substantial transport. So to come up with ideas like that can assist in those situations, I think is particularly exciting.
And it's based on that need. So I think that because it's not a catch-all, I think it's really about creating that toolkit or expanding it, right? And so just as Shannon is talking about for other areas that don't have all of the infrastructure or resources that we have, we're offering potentially through this feasibility study that we're doing, and then if we expand it and really show that efficacy, we're sharing that, this is the next thing that you can add to that toolkit, and it can be for anywhere.
Now, from the other side of it, Carly, when because you and your team are dealing with all this research, how are hospital staff approaching you? How are physicians, nurses, people who work here? How are they coming to you? Are you approaching them? How does that work?
I would say it's both ways. So a lot of times we have research leads, just like Dr. Fernando, within different areas who are actively engaged in research. Some really, really high functioning groups that are championing research and want to do more. So a lot of times they are coming and they're saying, I have this collaborator, there's a contact that I have, or a particular pharmaceutical has approached me. I'm looking at this potential intervention. I think that there could be a clear benefit to our patients, this subset of population. And so they'll say, well, what do you think? Is it competing with something else? We never like to open two studies that are competing with the same population because, we want to put our best foot forward.
Sure.
So they might approach us, or vice versa. Other networks might approach us, our research office, directly, and then we'll go back out to those physicians or research leads and ask them, are you interested in supporting this? But then there's individuals from other areas too. So sometimes we have nursing professionals that might come forward and say, I'm using this assessment tool, but what I'm looking at, I'm finding that there's a gap. There's a whole area that I think that is missing. I think that we could build on this tool that's already out there and that's, in use in their field. Perhaps we can develop something that's an add-on, like an addendum, or expand it. What do you think? Can you help me get going with this particular project?
And then what does it look like behind the scenes? Is there like a brain trust that gets together and says, okay, we like this one, we don't like that one? Is it an audition? Is it like trying out for the volleyball team and you have cuts at the end and everybody goes up and looks at their name on the piece of paper? How do you allocate? Because there are scant resources, right, everywhere.
Yeah.
How do you allocate those?
It's multifactorial. So I think that you're right. There is limited resources, and I will say that that's where we lean a little bit more on that community hospital side because unfortunately, we're not able to receive that direct government funding through the hospital. Ministry of Health, they provide direct funding only to the clinical services and other key support areas like your IT and your human resources. But for research, a lot of this really has to rely on grants and contracts.
Really?
Yeah. So that's a struggle. And I would say it's not just limited to our hospital. It's widespread across other hospitals, across other academic centers. And so we do have to look at it from that standpoint. So it's where are we situated right here? First and foremost, I would just say, is there the enthusiasm? Do we have the passion? Do we have the personnel that are willing to support this? A lot of times we do need leads to champion. And then, we do have to look at the funding model. If there is funding that can pay for that, sometimes we'll expand our team. We might bring on another coordinator or another nurse, and then we can do it that way. If it's more limited in some of these investigator-led studies, then we might have to pick and choose a little bit, or we might just delay our entry into that, a few months or 6 months, something.
Can you talk about the Red Council and the grant that you received from them?
Yeah, so
I hope it was a big check.
It's pretty sizable.
It's pretty sizable.
Okay.
When you're talking about, I don't think anybody has expectations that, get an entire trial funded. But the truth is that's not what federal agencies want you to do with seed funding. They want you to get a little bit of funding to prove that your idea has some traction.
Like shooting a pilot episode, kind of.
Yeah, that's exactly probably the best way to put it. And to Carly's point, people pitch research projects all the time to these major organizations. They want to make sure that you're serious about it and that you're passionate and that you you know that you're willing to do the legwork that's necessary to prove to them that this is a worthwhile investment of taxpayer money.
Yeah.
Like that's at the end of the day what it comes down to, right? There's, to your point, it's only so much resources, and those resources have to go to a lot of different areas. And you know, I think all of us who are taxpayers want to be sure that our the money that we give to the government is being used responsibly. And what I can tell people is that CIHR is extremely careful with giving out funding. And if you just came to them and say, hey, I had this great idea, I wrote this grant, what do you think? They'd say, prove to us something.
I don't want to do that.
Yeah, they prove to us something.
You guys will do that. I'm
Yeah,
like,
yeah.
I just wanted a bunch of money to have fun with.
Yeah,
Yeah.
they'll say, you know, before we cut you the big check, maybe prove to us that something that this works, some evidence that this is reasonable, some evidence that people care about this question, some evidence that people are variable in their use, and that's exactly what we use the funds from Lakewood Health Foundation to do. So, like that funding that we receive from the Red Council is for you know, funding seed work. Ideally, and I think that's how it should be looked at, is funding for preliminary work that is not necessarily a full trial that's going to prove your question, but will help you make a case to a larger agency that this is worthwhile getting large sums of money to run, and showing that you can do it efficiently. So this Red Council funding, we're going to run a pilot trial with 20 patients, small amount of patients. We're not going to answer a question with 20 patients. But when we go to the larger agency like CIHR and say, listen, we want to run a trial for 600, 700 patients, we already have a protocol that we
You got a
run
proof
with
of
20
concept.
Yeah.
with 20 people, it worked fine. They'll say, okay, these guys know what they're doing. They already have a protocol that worked. They were able to enroll patients. It's much lower risk for them to give us the funding to investigate this question. That's the hard part for them, being presented with, you know, just like hundreds of ideas
Yeah.
and only having the money to fund dozens, maybe.
I think the funding success rate, I haven't checked it in a while, but I think the last time I did it was probably about 18%
Yeah, it's
of
below
all
20%.
projects.
Below 20%.
It's like getting into
Yeah.
Harvard, right?
Yeah.
These are Harvard
Yeah.
numbers.
Yeah.
Exactly.
And then what exactly is the Red Council? Like, I'm envisioning something from Game of Thrones, right? That it's, you know,
Love
they're in
Game
this
of
like
Thrones.
giant cathedral, and like it's a group of people, I would assume. They're in
Yeah,
a building
they're all banging
somewhere.
their fists on the table
Yeah,
and
okay,
saying, "I
order,
vote for
order."
this one." Yeah, exactly. No,
Who are these people?
You know it.
Where is this headquartered? How did this operation kind of start? What's the genesis of the Red Council?
Yeah, so really this all started through some active participation through different members of our various foundations and our education teams and our research teams, and going around and saying, you know, what would really be helpful for us at our hospital is providing seed funds to, so research and education fund, that it funds exactly that. So it's actually split. It's $50,000. It's half and half, and it's split between supporting research proposals as well as education initiatives to allow individuals to upskill in a particular area. And so what happens is we launch this funding competition. We usually do it in the summertime, and we give a few months for individuals to put together their best pitch. And so we receive all of those, and we have a scorecard essentially that goes through, what are you looking to do? What is the need? Does it fit within our hospital strategic plan? What's the feasibility like? Do you have team members that are equipped and resourced to be able to complete this project? And then also, you know, what is the maintenance of that? What is it? What's the potential outcome? What's the good? And so those proposals are scored by a whole council, by a team. This Red Council is made up of different members throughout the hospital from various departments. And so we have leads from our research team, from our academic affairs, our equity, diversity, and inclusion group, from our organizational development group, and everybody gets together and reviews independently. And then we come together, kind of like that Game of Thrones cathedral table, and
order some pizza, some nachos.
Yeah. Oh, come on. This sounds
Well,
way
this is
more
healthcare.
exciting.
Should've done it that way.
Ordering some
Yeah.
salads with a little bit of lean protein. And
Exactly. Yeah. And so we really just rank them. And if some of the proposals are close, we go through back and forth and determine which ones. You have to draw a line in the sand because it's limited funds. Having $25,000, sometimes that's only one project. And so in particular for Dr. Fernando's study, it is going to require, you're going to do a whole pilot study. It takes that full amount. So unfortunately, no other proposals, as good as they were, and as viable as they were, we couldn't support anything else. Whereas this year, we just actually closed off our latest competition, and we were able to fund, I believe it was 2 separate projects.
Wow, okay.
So that was nice, but it limited resources. And so while the impact hopefully is going to be quite vast, we're only able to do so many each year.
Well, and you had mentioned, Dr. Fernando, that the government is generally providing money for the day-to-day operations of a hospital, right?
Correct.
And those are quite demanding, as they are.
Very important.
The Red Council, that's all donor money, right?
Absolutely. Yeah. Yeah. And so what we're able to do is once we move through each year, we ask any of the recipients to complete a report and actually come back and demonstrate what that impact was. Because we do have a reporting requirement, making sure that they are being spent in the best possible way and demonstrating what those results are.
And then what is your relationship, and I assume good because they're giving you money at the end of the day, your relationship with Lake Ridge Health Foundation? How are you working with them? Are you providing those surveys to them? Are you having quarterly meetings with them to talk about some of the exciting updates? What does that look like?
Yeah, it's through a variety of different ways. So most heavily, we work with them through the Research and Education Fund. However, we do have, on occasion, designated research funds that come through to support personalized research, new opportunities. So it might be specific to a program or to a researcher. And then I think a big part of this is really advocacy and communication. So ensuring that individuals understand what we're doing within our walls, what research means, what that success looks like. And so quite oftentimes I'll pitch patient stories or just provide different updates as to what we're doing within Lake Ridge.
Yeah. What do you think the future of this program looks like, the two of you? I'm curious, Dr. Fernando.
Well, I'm very hopeful. I think like what I've seen over the last 3.5 years has made me very hopeful that there's a strong appetite for research. You can have individual people like be interested in research, but you really need strong institutional support. Like, yeah, you just can't get that done.
It's a lot of moving parts. It's a lot of money.
Yeah.
Like it's a very, you're
Yeah.
incredible people, but you're individuals, right?
Yeah, there has to be buy-in, right? And I think that's what it's emblematic, I think, of the way Lake Ridge Health is being considered from what was like traditionally a quote unquote community hospital to now what is, I think, has a very strong academic slant. I think, as you mentioned, a lot of stuff about Queens and the educational aspect, but now having a strong research arm is also very, very important. So I do think that there's going to be substantial growth. I'm very hopeful this is not going to be the first investigator-led trial at Lake Ridge, and I think that will hopefully direct sort of recruitment efforts too in terms of the next cohort of physicians that are recruited to Lake Ridge Health. It's going to be just like any other academic center. Tell us what your academic plans are. It's not, I'm really interested in providing good clinical medicine. I think we all are. It's what
that seems to be the bare minimum.
That's
right?
the bare minimum.
And
In a lot of medical training, a lot of people who are not interested in academic endeavors for whatever reason, their sort of slant is, well, I'm not going to go to a major academic center. I'm going to a quote unquote community site because I won't have to do or worry about academic stuff. But
meanwhile,
it's changing.
Calls coming from inside the community
that's
hospital.
Right. It's coming from
Absolutely.
inside, and so I think that's a really hopeful change.
I'd love it if we could talk about, like, if I had an idea, let's say, and I'm looking at my hands, I'm like, a cure for Raynaud's would be great. Can you take me through, you're like, I want to get this, I want to study this, to, okay, we've had 500 people enrolled in this study and we finally have the results. I assume that's probably a couple of years, to put it conservatively. What happens on day one? How do we get to day 6,000 or whatever?
Yeah, absolutely. So I think first and foremost, it's, starting with that research question. Are you questioning something? You talked about
why do my
Raynaud's,
fingers
right?
look like white asparagus? It's so cool.
So you go, here's what the problem is, and then you need to find out what's out there right now. So you need, we call it a literature search.
Okay.
So that's something that, we're
Needs
really
to be updated probably for 2025.
all the time.
Yeah.
So, but you do what you do is you look at all the literature, primarily within the last 5 years, but sometimes you're going back just, to the very beginning, as many articles that you can find that have been published about that particular topic and seeing what's been tried before. And so at that point, you're really looking to see, has anybody tried this? Is there evidence, or are we really, without a cure for that? What's the next step? And what you really want to do is build on that knowledge. And so what Dr. Fernando was talking about earlier is they were looking at sepsis and methylene blue. And so that's where they really started, was with a literature search. And we're really fortunate here at Lake Ridge because within the last couple of years, we just recruited a managing librarian.
Nice.
Yeah, and so that's somebody who's actually just down the hall from us right now, who can actually
Let's
sit
give a
there.
shout out. Who's the
Yeah,
librarian?
Justin. Shout out to
Shout
Justin.
out to Justin.
Yeah,
J-Bomb, what up?
absolutely. And so he can support with that in pulling all those publications, and then it's up to somebody like Shannon who has to go through and kind of synthesize that information.
Okay, so we have the problem.
We have the problem.
We do. I'm gonna be very reductive and say we do a quick little Google search.
Yep.
Type it into Bing. We ask Jeeves, and Jeeves
Scientific
goes,
Google search.
Of
I mean,
course.
come on, need some credibility
Google
there.
Premium
Google
or whatever.
Scholar.
Yeah,
Yeah,
which I'm sure is coming pretty soon. And then you find out what you have. You find out what the lay of the land is.
Right.
Where do things like the Red Council, which is funded by donor dollars here at Lake Ridge,
Yes.
the government you were talking about, the CIHR,
Yeah. So,
those kind of things. Like, is that the next kind of step up?
so the next step up for us here is the Red Council, the Research and Education Fund. And so our operations, our offices do a shout out and we kind of say, hey, who's got those ideas? Who wants to pitch that proposal? And so we receive all of those and we score them. And then as mentioned, Dr. Fernando was the recipient in 2024. And so he's able to establish that literature search that we were talking about. It was able to fund some of that, the publication costs, because why should we be able to publish for free? Nope, there's always a price tag attached
Yeah.
to that. And then
Capitalism, baby.
Yeah. And then what he's able to do now is that pilot feasibility study, and that's the proof of concept, saying this is a viable project, and we have to, that's really that baseline. It's a standard now that larger funding agencies require. You can no longer just throw your hat in the ring. You really have to demonstrate that evidence that
But you've got support of your own.
you've got buy-in.
You've
that
got an
it's
audience. You're bringing an
possible.
audience.
Absolutely. And you can't do that on your own. You have to rely on a larger funding agency. So we're looking at charitable organizations. There is the government funding agency. So the Canadian Institutes of Health Research is one of the biggest ones in Canada for us. So for short, we call that CIHR. And that's where you're actually able to go from that tens of thousands all the way up to hundreds of thousands, potentially more, depending on the competition, if you will.
Yeah.
And you have to structure a budget around that. And that's where you're going to break down and you're going to say,
Like in tiers?
Yeah,
Or you're gonna break
sometimes
down how
when
to
you're
go through
writing,
this.
it
Yeah.
can be that
Sometimes.
way. Yeah, yeah.
Not
I don't
speaking
know.
from
I'll
personal
ask him.
experience or
Yeah.
anything.
Yeah, the
He
eyes are
just-
looking a little moist. I caught that. You're like, oh, flashbacks.
I think you're writing at what, probably 2:00 in the morning.
Yeah,
I get emails from you at
lots
the
of- yeah.
most obscene hours.
Yeah.
I'll catch those in the morning
Yeah.
though.
Yeah, I think Carly's point is well, it's a journey, right? When I sort of talked to people and said I'm really interested in studying methylene blue and sepsis. I wonder if it could be effective. Everybody said to me, just so you know, you're signing up for like a 5-year journey,
Yeah.
possibly longer. Because that's what it takes. And, I think the stepwise approach is to ensure that everything is done actually as efficiently as possible when it comes to using funds. And we're really grateful for the funding that we've received thus far. That's allowed us to get to this point that to Carly's point, we've passed, through Red Council and the funding we received and used that, I think, in a way to create a really great story that's compelling. And now taking that story and going to government agencies and asking for now the bigger check to run the bigger study. But that wouldn't have been possible if you didn't back up to a year and a bit ago and submitting for the Red Council grant. So I think those of us who are fortunate to receive that kind of funding, it is truly like an obligation to ensure that it's used wisely in a way that promotes the program and that people who kindly donate to these kind of endeavors can know that the funding was used responsibly and for something that will ultimately help not just the hospital but potentially the country, potentially internationally.
Well, and then you see your dollars in work and you see your good ROI.
Yeah.
I think people are probably encouraged to donate more. And once you do something, once people in your tribe do something, and you see that it works, you have the confidence and it seems easier and more accessible for you to take part as well. Whether it's donating, whether it's, enrolling in yourself or
Participating
enrolling in a family
trial.
member.
Yeah,
Exactly.
Yeah, exactly.
We get to CIHR. We've got hundreds of thousands of dollars. We're signing up for a 5-year thing. My daughter's about to turn 5, so I intimately understand what a 5-year commitment looks like. And how do we get to now? You've got the money. You've created the budget. You've signed up for all of this time. Now you're at the end of that 5-year period. What have you accomplished at that point? What is still left to do, generally speaking?
So, usually once you've received the funding from the large government agency, you can start to build the infrastructure. And I think, again, we already have that infrastructure in place by doing this pilot. So I think that that's one of the reasons they're more likely to fund you, is that you take that and then you start enrolling patients into your trial. And again, if you've done this appropriately with the right forethought and the right experience and with the benefit of pilot, you should be able to reliably predict when you're going to be done enrolling patients and reach the number of patients you. And then once you've done all of that and you've recruited your patients and you've gathered the data, then it's analyzing the data, publishing the data, and then, as we discussed earlier, knowledge translation, getting those results out to people to say, this is how we use this funding to do this trial. These are the funding,
The
these are
marketing
findings
part of it.
Yeah, these are the findings of the trial. There's a huge marketing part to it, and I think a lot of you've seen over the last several years, researchers get on major social media websites as a means to propagate their ideas, not just to the general public, but even to our colleagues. If I've got a colleague of mine who's working in ICU in Red Deer, Alberta, and they
Even
need to
no idea what you're doing
no idea what I'm
necessarily.
doing over here, and so that's a way to quickly show them and say, these are the results of the trial. This is how this should impact your practice. And there's been a huge rise, and I think to that degree, we should credit social media, podcasts like this that help with the aspect of knowledge translation, which is so critical, that you're not working in a bubble or in a bunker and created an idea that no one else is going to know about.
Yeah.
And I think that's one of the most important parts of conducting a trial. And that entire process, although we went over it in a few sentences, is 5 to 10 years of somebody's life. To get an answer to a question, does methylene blue work in septic shock? That's how long it's going to take. I think that's an area that we're really expanding at Lakeridge, and I think efforts like this and
Thank you.
Just there's a culture of research here, and I think that becomes an expectation. I think your example of dealing with cancer and is so apt, and I think that's been something that people have long time associated with research, but it's also usually at major cancer centers. When you go to a major cancer center and you've got cancer and you're thinking about treatments, you're almost expected they are going to be asked or try to get into a trial or whatever.
The amount of paperwork I don't think
Yeah.
I've ever signed something. I wish I worked on my signature. Had
Yeah.
something
Yeah.
a little more attractive, because it's and I said yes. I'm like, whatever you need, absolutely.
Yeah.
I feel like that's. And everybody can make their own decision. For me, I'm like, absolutely. I'm getting all this care. I don't have to pull out my American Express. I'm happy to provide whatever I can. And I imagine that that's the case with a lot of. We talked about this earlier. I imagine that's the case with a lot of people.
I think people want to, and I think, but once you create that culture, then it becomes more acceptable and people are more understanding of it. And I think that is the area that is most exciting to see Lakeridge Health grow in. Is, like I said, a transition from what is a traditional community site to a combined sort of academic community site, and I would say more of an academic center, to be honest, truthfully. And people's expectations, whether they're attending physicians or other allied health workers or trainees that are coming through, or patients or loved ones, is this is a center that does research. I think that's really exciting and something to look forward to for the future.
Ontario Tech, which used to be, and I got to say this slowly, UOIT,
yes,
right? Otherwise,
yes.
UOIT just kind of slurs together. Can you talk about the partnership with them? How long has that been going on for? And what are some of the really cool things you're working on together?
The partnership is between Lakeridge Health and Ontario Tech, and we signed a formal agreement back in October, I believe it was, so back in the fall of 2024. And so it stands for Partnership for Advancing Technology in Healthcare.
Is that an acronym as well?
It is.
I was trying to do it in my head.
PATH.
PATH, okay.
Yes. So it's really exciting. This is not a new thing that we've been working on. Actually, there's been a lot of conversation and, of course, background work that's been happening
Sure.
for almost a year. And so it's really about aligning our expertise. So within the hospitals, we have a lot of patients, we have a lot of healthcare workers, a lot of clinical expertise. We've got a lot of problems. We have a lot of diseases that we need to advance care on, treatment
Like
plans.
sepsis.
Like sepsis, absolutely. But then on the Ontario Tech side, they have a lot of individuals who are researchers in engineering. We have folks that are specializing in advanced technologies such as AI. So that's pretty exciting. And what we need to do is see if we can actually come up with new solutions that, if you're looking at doing AI within human care, that can be a little bit scary because we never want to remove that human-to-human interaction. But we're looking to see if we can do things like streamline different workflows, whether that be through scheduling or documentation for clinical notes afterwards. You need reports afterwards. It's very labor-intensive, very administrative. I'm sure Dr. Fernando, spends hours upon hours
I can see the
doing
stress
that.
in your head, your forehead wrinkled. I'm like, oh, okay, yeah.
Yeah.
Like a Pavlovian reaction when I see that. Yeah.
Yeah.
That's
But
another
then-
15% though, right? The 85% is you were mentioning this earlier, the clinical, the nuts and bolts, and
Yeah.
then the 15% or the bread and butter, I guess. The 15% is I don't want to call it boring, but things that can be boring to some people, I guess. The
But they're
scheduling
necessary.
thing. Of
But they're
of course.
necessary. Yeah, absolutely. But then there can be more exciting things. You can use things like AI to look into imaging, to help with diagnoses, to predict things, to do predictive analytics, for instance. And so I think that there's great opportunity with that. We'll move into it. We'll start more on the administrative side first.
How do you see that integrating with future studies that you're going to be doing? Like, do you think that that's more of, because it can be buzzwordy to some people, AI.
Yeah.
There
Yeah.
are legitimate benefits. I think people are scared of this, but much like enrolling in a clinical trial yourself, the more people that do that, the more comfortable we all come. You had said that earlier. How do you think that's going to weave its way into some of the projects you're working on in the future?
I think it's probably, while it might sound daunting right now, it's a disruptive technology. And much the way that a calculator was, a car, your cell phone, these are all disruptive technologies, but these are things that, we take for granted now. We can't imagine our lives without it. And
I'd like to imagine my life without driving. That'd be
yeah,
nice, you
yeah.
know?
Maybe we'll go a little bit further into time travel or
Teleport?
portaling.
Yeah.
Yeah, exactly.
Or just stay in our homes, like it's the winter right now. I just
Yes.
want to stay inside.
No, I think it's just going to be the way of the future. So it'll just be second nature to us. And we're going to have to, because there's less people going into healthcare. There's more patient volumes.
Why are less people going into it?
Well, I think that there's a variety of reasons. I think that it's
They can't compete. They see the two of you. They're like, there's no way I can't hold a candle to that.
Well, I think that I don't want to reflect back on the pandemic, but I think that it has changed the course for some individuals in terms of earlier retirement, or maybe not staying in as long, or looking at different career pathways. So we have more patient volume. Our community is increasing, and there's actually a global healthcare shortage in terms of workers. So what we need to do is we need to work smarter and not harder.
We talked in a few other episodes about things that the foundation is funding, like the Da Vinci robot, like the PET CT scanner. And I'm curious, in the arena that you're both working in, how you're using this to attract new talent, right? Like, you've been here, Dr. Fernando, for 3.5 years. I'm curious how you're looking for the other Dr. Fernandos of the world. You're unique. You're one of a kind. We're all special. I get it. That's not what I'm saying. But how do you make this attractive for people? How do you say, if you're going to work in healthcare and you're going to work anywhere, come chill here?
I mean, I could give you a very sort of critical care centric view on that. Critical care is a very tough job market. And that's mostly because
It's demanding.
ICUs are limited, right? There's only a certain number of them, and we're training new people every year to do this, and the number of space in ICUs is not increasing. So, the competition for jobs has certainly gone up. And I think, to your point, the bare minimum these days is just be clinically very good. And so a lot of us, I think, pursue research because we're interested in it, and also because, it's something that would be helpful in a career. Because when you're pitching yourself to various centers, you're trying to say, I'm clinically good and I do X, Y, Z. And it has historically been the case that, and I can say this from my own experience when I was finishing, there's only so many centers that you're really going to consider research a huge value add, right? You're going to, and to be honest, in my first year of fellowship, Lakeridge wasn't a place that was on the radar. You're talking about big academic centers where Carly and I used to work. That's you're presenting for a job, you're presenting to like 20 people. This is my
Sure.
research plan. And I did that to a bunch of different places. And, I think what is amazing is now to put Lakeridge up there as a place that actually, if you are interested in adding value as a researcher, that's something they're really interested in, which is probably not something that somebody would have said to me early on in my training when I started in the mid 2010s when I was a resident. I don't think anybody said, hey, if you're really interested in research, you should really consider Lakeridge Health. I don't think that was something that was ever said. But I think now, as somebody who's doing
shift.
research,
Big
I can tell
contender.
people, I could say, you know what? We're actually doing a fair amount. There's a lot of institutional support, because that's what people care about when they're doing research is, am I going to be there stuck slaving by my own with no support, or is this going to be a place where if I come to them with an idea, they're going to be supportive?
You don't want it to be a hamster wheel.
Correct.
Yeah.
You want to actually,
Yeah.
you're generating motion. You want to actually get somewhere, right?
Yeah.
And I think that that's a really amazing thing to say. And I think the education aspect of Lakeridge has really sold itself over the last 5 years, expanding all the time with medical school classes, family medicine program, et cetera. But for researchers to now say, well, this is also a place that's running clinical trials, a large amount of clinical trials, and now leading their own clinical trials, getting funding from massive agencies for clinical trials. This might be a place that you might consider doing any kind of research, whether it is clinical trial research or more observational research, database research. There's a lot of value in all kinds of different study designs. So I think that's very impressive and something that we should be proud of here at Lakeridge, and a really great way to change the vibe of recruitment. So instead of being, listen, we just want somebody who's going to come and do their hours and go home, it's like, no, this is like any other academic center now. But there's going to be expectations to do other things. But on the flip side, if you're that person who's looking for a job in academia, this is now a place that's on your radar. And I don't think that's what people would have said even 5 years ago.
Looking at research here at Lakeridge Health, it's really about sustainable growth for us, and it's just about expanding access. So that's one of the biggest things we talk about. I know that you went for your stem cell transplant down at Princess Margaret downtown. I can imagine that was quite the hike, despite the fact that, you're a couple of hours from there, but it's probably very exhausting for you to go down, receive that treatment, probably very expensive. We were talking about gas and sort of our pre-interview setup here, parking, everything that way. And so what we want to do is take that burden away from our community members. And so if they are looking at participating in things such as clinical trials, bringing that closer to home for them. And so if we're servicing the 750,000 people that we were talking about earlier, we want to provide that support and that care, that opportunity to them in their backyard, essentially. And so,
could you come to my, but hopefully I don't get a cancer third time, but could you come to my backyard next time in the summer? I'll get the barbecue going and all that, but that'd be nice.
Maybe not. Okay. It'd be really hard to pack everything up and bring it over there. But what we can try and do is that when we open new studies, what we'll try and do is work with our leads, our sponsors, and we'll say, well, hey, can we pay for your parking as you come here and participate in this trial? Or, if you're coming from a further region such as Peterborough, can I pay for your gas to allow you just to break down some of those barriers a little bit? And if it is close to home, then hopefully that takes a little bit less time out of your day and you don't have to have that extra exhaustion of going, whether it be downtown Toronto or, looking at potentially considering out of country. We don't want that. We want to bring more research into Canada and even more into the Durham region.
Thank you so much to the foundation and the Red Council for funding our work. I meant it when I said it was a true obligation to get those funds and ensure that we were using responsibly. Having just gone through a major pandemic, I think a lot of people's trust in healthcare was eroded. And I think for a lot of people, research kind of went with that, and they have look at it with a little bit more distrust. But I hope that people who listen to this and meet people who do research will see that people who do research are really passionate and caring about improving care for healthcare for others, and not just in Canada but around the world. But we can't do it without the help of patients and their loved ones who volunteer to be involved in research. And I hope that they can see that information over the last several decades has led to immense advancements in healthcare, and we're all very hopeful that will continue.
Thank you to Carly McPherson and Dr. Shannon Fernando for joining us on Brace for Impact, presented by Lakeridge Health Foundation. Brace for Impact wants to give you a sneak peek behind-the-scenes look at how donor support makes all of this amazing work possible. We want to inspire you. We want to motivate you to make a difference in your own way, because it's people like you who are making a difference in this community. My name is Coulter Bouchard. Join me by giving or getting involved at braceforimpactpod.ca.